and on research, especially the basic research. Though we have got lot of clinical material, maybe we have to request with our government the separate budget for the cancer research. That is very much required. Thank you. We'll go to the next topic. Madam Jayashree, she is a young dynamic laparoscopy surgeon. Earlier, 3 decades back, with the cancer surgery, we used to lose lot of patients with the large incisions. This laparoscopic surgery has given us a lot of refinements in the surgery, and Madam is practicing that. And we had associated with the long incisions, very, very bad infection also. So we used to lose patients with the septicemia and all. That is not the case today. We will hear to Madam Jayashree. Over to Madam Jayashree.
Good afternoon, everybody. Let me first say thanks to all of you, and typically Dr. Nagaratna and my friend Dr. Vaikar from Pune, who has been instrumental in giving me this opportunity to have a word with you, and something which is going to be discussed now is something which people probably don't know. It's a huge change in the paradigm as far as the disease is concerned. Like we heard about few things about cancer, we know that cancer today doesn't have any cure known. Diabetes was one disease which was thought to be, once you get it, you will, the disease and the person disappear at the same time. Now, thanks to the modern technologies, the sciences, the advances in the research, and we are able to understand diabetes with a better perspective. We are able to understand diabetes, which is coined with obesity, which is called as diabesity. Diabesity is the term which comes from WHO, wherein they have coined this term typically addressing the huge correlation between diabetes and obesity. When anybody in the healthcare is going to treat any patient, what we aim it as the final quality of life. Quality of life in terms of physics, in terms of psychology, in terms of social manners, in terms of sexual performance, all these things come when we are tackling any patient and any healthcare is tackling any kind of disease. So typically this should be the aim, not just removal of something or not just removal of some disease from the body. As I said, WHO has declared this as the global epidemic, and let's go through it one by one. It will be very interesting knowing how the terminology has come, how the perspective about the disease and the treatments have changed over the last 2 decades. We all know about this. The incidence of type 2 diabetes is growing globally like an epidemic. It is declared as the second killer disease for the world in this century, first one being the HIV or the AIDS. And look at this, the number of people which are suffering from this disease, maximum in India. So probably we have to gear up ourselves to take this challenge, because in case all these people come to us for treatments, probably we are not very well geared up as on now. Let's try to understand how we can deal with this burden. Challenges do not come as just diabetes or just obesity. You know that in our country, the first, or anywhere in the world maybe, the first reaction to any disease is denial. I don't have diabetes, I am not obese, it is just something. And you and me know that there is nothing like just something. We have to treat the disease when it is probably not yet complicated. And probably that is the best time when we can make the best reversals of the disease. Look at this gentleman doesn't come to me with obesity, he comes to me with the gynecomastia, enlarged breast which troubles him, not his obesity. This gentleman doesn't come to me with a lot of diabetes, which is highly uncontrolled in spite of huge units of insulin. He comes to me because he is unable to bend down, he is unable to have his breathing comfortably and sufficiently even with the CPAP machine. You all know that obstructive sleep apnea is one of the biggest dangerous causes of death in people who have got central obesity. Look at this person. He comes to me with lot of liposuctions done, lipectomies done. He doesn't understand from where the fat is coming. He is removing again and again. What's going wrong? The varicose veins are troubling him. He is unable to walk. Many people tell him, go to some dietitian, get something done. He is unable to understand somebody is losing weight, but I'm not. What's going wrong with me? Look at him. And this is not an unusual picture in our family and our friends. In fact, in India, the disease is running in the families. Why? Two things important. One is genetic predisposition. We are the diabetogenic and obesogenic population genetically. And number two, culturally, we are fond of carbohydrates. We have forgotten that our previous generations used to take lot of carbs, but they used to do lot of hard work also physically. So when we say that, okay, our grandmothers used to eat this and they never had disease, why should we have? But the amount of hard work they were putting in physically, are we doing it today? No. Then probably we are the wrong claimants for the same kind of food. And this thing needs to be understood by all of us and percolated again towards the society. Look at this. Somebody is struggling with the uncontrolled hunger. She is like this in spite of huge attempts to keep her hunger away. So my question to you is, when we are trying to treat obesity and diabetes, we understand, we tell them diets. Only 20% can follow, 80% of them cannot follow. If I am going to treat only the external dish in front of these people and I am not going to touch with their hunger patterns, then probably I am doing wrong to them. I have to treat the hunger, I have to make them satisfied, and then only probably I can tell them, okay, I am eating only apples and you should also eat apples. But what's going wrong in these people when we call it as uncontrolled hunger? Let's try to understand, can we go like this? You and me try to eat tons and tons of food, can we grow like this? No. So let's accept the fact that obesity and diabetes are the diseases which are metabolic diseases, which are not just lifestyle disorders. These are the people who are struggling, nobody is happy like this. Of course, willingly, no, they are not going to be remaining like this willingly, but they are helpless. So my first message to you all will be, when we are tackling any kind of diabetes or obesity patients, we have to be compassionate. We cannot be blaming them for eating a lot unless and until we understand where from the hunger is coming. And this can come in multiple ways. It can be just central obesity with lot of metabolic problems, like the first gentleman you can see, who is suffering from diabetes, who has got IHD, who has got angioplasties, who has got kidney failure, who is suffering from n number of metabolic diseases. Look at the second gentleman who looks very, very obese. He doesn't have any of the metabolic diseases, but mechanically he is unable to perform so many things. These two can be the varied images how obesity can present to you. It can be either metabolic or it can be either mechanical, but both of them are obesities and both of them need to be treated as diseases and not just lifestyle things. Why do we need to talk about it? We all know there is a steep rise in the mortality rate once the BMIs go high. We also know that the number of people, young deaths, premature deaths, happen in obese 100% more than the non-obese counterparts of these people. We also know that we have got n number of diseases which come with obesity, which include your diabetes, your hypertension, your cholesterol, your infertility, all the hormonal problems inclusive of your thyroid. These things are going to come to us. Why? Because the machine which is given to us is able to tackle up to BMI of 30 easily. Beyond that, it fails. If we are going to treat the failed systems only, without taking care of the burden, then probably the systems are going to fail and fail and fail more. This is one very famous slide which talks about why Indians suffer with diabetes more over than anybody else in the world. We are thin fat Indians. We look thin, but our fat content is much high. We are sarcopenic. We have got less skeletal muscle. Genetically, we are sarcopenic, but with our habits, because we are lazy, we are more and more sarcopenic. My appeal to you all will be, because you are in the forum where the yoga is talked about a lot, it becomes our responsibility to make our society arouse towards this, that they have to do a lot of physical exercise to build up their skeletal muscles so as to make their own machines geared up to take this challenge. We all know insulin sensitivity comes with the skeletal muscles. The number of lipids, what we call it as myocellular lipids, if they are high, then typically the insulin resistance comes in. The myocellular lipids have to be burnt out. The muscles need to be made better and better toned to tackle the insulin resistance. And here we play a big role as far as we look upon yoga. I mean, we expect a lot of things from yoga as far as the myocellular lipids and the muscle strengthening is needed. So when should we start the treatment? We saw the first thing is denial which comes. Even the doctors say that. You are just 100 kgs. Be comfortable. Forget that sentence. We have to tell them, you are 5'6", probably your body can take only 75 kgs as okay. 10% here and there is again okay. But more than that is a burden. Burden to your knees, burden to your pelvis, burden to your systems which are tackling the energy, that is typically the beta cells of the pancreas. Beta cells of the pancreas go into a hypertrophy, hyperplasia, and initially a lot of exhaustion, where you will see that the patients come to you with very high uncontrolled sugar. Why high uncontrolled hunger? Why does it come? A pre-diabetic is a person where your beta cells are exhausting literally themselves to combat these high sugar levels because of insulin resistance. Ultimately what happens is the hyperinsulinemia which comes to you. You know, insulin is a hunger hormone parallel and equivalent to working with that. So what happens is hyperinsulinemic patients are going to be highly hungry patients, wherein they are unable to control their hungers. They have got typically sweet tooth, they are volume eaters, and unless and until this insulin resistance is tackled with, the beta cells go into a mode of exhaustion and death, what is called as apoptosis. So typically remember, the day the patient is diagnosed as diabetic is the day where 80% of the beta cells are died. Are we going to wait till the 100% get death and then only we start with the treatments? No. The day you see that the fasting blood sugar level of a person is 100, that person needs to be under treatment because already 80% of his equipment is gone. We have to treat diabetes, we have to treat obesity with a very, very serious angle because of this. We understand that the caloric requirement, the caloric intake for these people needs to go down. Why it cannot go down? Let's try to understand a little more about the disease. Look at this. This is the hunger hormone, which is ghrelin. The middle one, if you can see the graph, this is 24 hours of a graph of a person who is eating normal foods and normal food patterns. This is called as ghrelin graph. The ghrelin graph in between you can see at the breakfast it goes high, we are hungry, we go and eat. At the lunch time, till the time the lunch comes up, it is again better, but at the lunch time it goes high. Why we typically eat 3 meals? Because the ghrelin pattern is like this. Look at the upper one. The upper graph will tell you that when I am doing a forceful dieting, or maybe when I am providing to myself lesser calories than what my body demands, what happens is the ghrelin levels are going high. And typically after the 40th day, what is happening is the levels stay high and the people say that we lose control. Are we talking about a psychological disease? No, we do not send them to psychologists. We are treating them as doctors because the patient is suffering from this disease from the metabolism which is within the systems, and it is not a psychological disease. Remember, when somebody says, I cannot control, that person is helpless. Do not blame that person and do not start with antidepressants to them. Look at this, we have to control their insulin resistance, which is not letting the tissues utilize the flooded or maybe the flowing sugar levels in the body. There are two compartments in the body, you all know, extravascular and intravascular. Within the vessels, the blood is flowing with high sugar levels, a good amount of calorie levels, and good amount of cholesterol. This is all the form of calories. This is all energy. What is the tissue doing? The performance is done by the tissue, and the tissue systems go into inactivation mode because there is something which is called as utilization machine which is failed there. The tissue is unable to utilize the intravascular calories they are flowing. That's the reason when you tell these people to remain hungry, to go on diets, typically beyond a certain limit, nobody can do it because the tissues remain hungry. Unless and until we correct this problem, probably we are not giving them the right treatments. I need to link again the missing link between the extravascular energy and the intracellular energy. This is where my treatments are going to aim at. So what is the final aim of this treatment when we want to give anybody this kind of treatments, treating their diabetes, treating their obesity, or the combination? We are looking upon ghrelin levels which are stabilized, ghrelin levels which do not show fluctuations, and ghrelin levels which make them compliant towards the diet. How do we achieve it? This is typically a person who comes to you, lot of metabolic problems, a very high risk for cardiovascular death or cardiovascular event, you can say. The aim is, unlike we are seeing this disease discussed by business people and the industry in a very, very superficial manner. They have made the comedy of obesity. Obesity is not comedy. Obesity is something which has got a very, very deep dimensions to understand, which are touching base with each and every system of our body. We do not work on the inch losses. We do not work only on the kgs of loss. What we work upon is metabolic restoration. What is metabolic restoration? The tissue needs to be equipped to use the energy which is available to it. If this equipment is provided, then probably the things are going to fall in place without needing anybody else. The outcomes expected are like this. The cholesterols have gone down, the HbA1c has come down, the diabetes is pretty under control. The cardiovascular risk, in the previous picture if you see, it was more than 35%, has come down to 3% in this person. And this is the outcome which we expect out of any treatments when we are treating any patient. So what are the treatments available with us? We understand that we need to define at which level the treatment should start. What are the different levels available with us? The consensus statement for Asian Indians, fortunately we formed this consensus in 2008, and I was one of the part of these core groups who formed this consensus. We talk about up to 25 BMI is an acceptable BMI, provided we take down the fat percentage to less than 20%. To my surprise, to your surprise also, if you try to understand, people who come to us or may not come to us, just do their body composition, you will understand even at the BMI of 22, 23, people have got 50% of fat. For me, they are sick people. And if somebody is 100 kgs with probably just 22% fat, for me, he is a less sick person. The fat percentage is going to decide exactly where you want to focus your treatments on. Till the BMI of 25, probably we can say they are able to manage their bodies. But with 25, with any of the comorbidities which is related to obesity, which we discussed in the beginning, they are the people who should land up into diets, exercises, and if need be, some medications. People at the BMI of 27, the fat percentage grows so high that they become highly predisposed to multiple diseases, and they should be the people who should be following diets and exercise for sure, even before any appearance of the comorbidities come. But people who are above the BMI of 32.5, by now the medical science has understood that the metabolic set point in these people has changed to a great extent, which is very, very difficult to fall back within the normal limits with just diet and exercise. So that is where we say that some people respond, some people do not respond. Exactly what goes wrong? The metabolic set point, that is the responsiveness of your body towards the treatment, is something which is going to play the role. And here we are going to talk about some metabolic manipulations of the GI tract, that is the gastrointestinal tract, which is going to change your metabolic set point and make many other things work in a pretty normal way. There are different GI manipulations, that is the digestive system manipulations done to achieve this metabolic set point restoration. There is something which is called as a band, something which is called as sleeve gastrectomy, something which is like a gastric bypass, and something which is like a biliopancreatic diversion. Almost 19 types of different operations or the GI manipulations exist, which are going to make the metabolic restoration of these patients. Exactly how do we decide who should go for what? It depends upon many things: the fat percentage, the BMI of the person, the age, whether the person is in the growing age, whether the woman is in the fertile age, whether she expects any family ahead or not, the gender of the person, the diet pattern, the cultural habits, the food linking of the person, lifestyles and behavior, how much he is able to donate his time towards the physical activity on a regular basis, the existence of the metabolic syndrome and its severity, the medical risk of the patient, and the final expectations of the individual. So these are going to be the tailor-made treatments which are going to change the complete scenario. We have to discuss many things with the patient. We in our unit discuss with the patient about the nutrition, about the food habits, about the expectation, about the performance level which our physiotherapist does, and finally we come to a conclusion what type of treatment should be best for them. What outcome can we expect? The expected outcome will be something around 50 to 80% of the excess weight which can go away after these operations. And is this only the weight? No. We talk about the mortality rate and the expenditure on the comorbidities, which comes down to more than 81% in these people. And if you compare the overall mortality, even at the 11 years, the mortality has fallen down to more than 31% in these people. What we are looking upon? We are not looking upon thin people, zero figures. No, we are looking upon, that is going to be a cosmetic advantage. But forget it. Because of cosmetic advantage, probably the treatments are looked upon with a very superficial eye, which is wrong. As we said, it has got deeper dimensions, and those should be tackled very well. Look at the targets and dreams which are achieved. People who were unable to walk, people who were unable to sleep without oxygen and CPAP machine, people who were on multiple units of insulin, like as much as 150 units, have been off insulin, no medication as far as breathing pattern is concerned, and people who are able to walk now. Look at this, the varicose veins have disappeared. People have got their hernias repaired naturally, because it's like, it's like some bag which is getting torn. That is why obese people will always have more and more hernias. These people, if we reduce their intra-abdominal pressure, what happens is the whole thing tames down, and typically the hernias may not need any kind of treatment in these patients. The varicose veins get healed on the varicose ulcers, they get healed on their own. Of course, this is going to play a big role as far as the skeletal system of the patient is concerned. And here I want to mention what is the role of yoga, what we want to draw your attention to. With central obesity, the complete skeletal system goes into an haywire situation. What does it mean? The complete back, the complete vertebral angles, alignments change. The patients undergo repair for the disc, patients undergo a lot of operations for something where the ongoing cause still remains with them. So central obesity will disturb your vertebra. The central obesity will disturb your pelvis. Central obesity will disturb your gait. The central obesity will give rise to lot of changes as far as the knee, the ankle, the foot of the person is concerned. And unless and until this is treated, we cannot get back to the normality of alignment. This normality of the alignment doesn't come back with only removal of the central obesity. What is important is going back and taking into consideration the paraspinal muscles which have gone into a fibrosed mode. If you see, people literally start bending after this. Obesity will give rise to shortening of the height of a person, because the vertebrae start collapsing, because everything goes into a waddling shape. All these things can be reversed if we take care and if we practice something like yoga or good extension exercises for the back. That is going to be a helpful situation for these patients. Because as I said, the purpose of the treatment is not going to be only weight loss or no diabetes. Purpose is going to be get them back to a fully vital kind of situation as far as physique is concerned. Look at this gentleman. His gynecomastia has disappeared. His testosterone levels, which were bad, have come up, and he is able to lead a confident life. Look at this girl. Again, the same thing. Uncontrolled hunger has disappeared. Pre-diabetic situation with high levels of insulin has gone down. Her beta cells are now going to be staying with her. So treating obesity and treating pre-diabetes is going to save the population from going into diabetes and the complicated diabetes, as we can see. Look at this, the infertility gets treated after this. What happens is when we are going with a lot of fat cells, I mean the hyperplasia and hypertrophy of the adipose cells, we know that is the biggest endocrine organ of the body, which is going to lead to n number of hormones and enzymes and peptides secreted. All these things disturb the complete milieu of the environment of the body, and what finally leads to is a lot of sexual dysfunctions, a lot of infertility-like problems. When patients come to you with PCOD, when patients come to you with hypothyroid, please remember that is the first sign that your body has sensed that the fat cells are going wrong somewhere. They are the smartest or the most sensitive organs which are going to pick up the problems first. So do not neglect it as a disease of ovary or disease of thyroid. It is the disease of fat which is presenting like that. Once you reverse it, look at it. Obesity and diabetes, I think, have got the best outcomes in terms that when we try to reverse them, the whole situation starts changing 360 degrees or more maybe. Exactly what does it do? When we operate on these patients, what do? We do not remove any fats. We do some changes laparoscopically in the intestinal design. And how does it help? It acts on the insulin resistance which is created by certain parts of the intestine. It acts on the insulin sensitivity which is going to be impacted through certain intestinal manipulations. It acts on the GI tract which are going to send some hormones which help the insulin and which decrease the insulin resistance. It works on the liver in terms of neoglucogenesis which is getting created by the liver. It works on the pancreas, making the beta cells more sensitive in terms of outcome, in terms of response to the high calorie diets. And finally, it works on the adipose cells in terms of getting them more healthier secretions than the diseased ones. So when we talk about these operations, we are not going to talk about something which is eating less. We are going to talk about providing the tissue with enough calories. The link which is missing between the tissue and the calorie is going to get bridged again, and this is going to help the patients come out of this high calorie syndrome with the tissue which is hungry still. So these are the operations which are called as neuroendocrine operations, which are going to impact the complete satiety and appetite pattern of a person. I'll just quickly go through 2-3 slides to make you understand. These are very, very elaborated ones, but I think this is not needed here. Look at this. This gentleman again comes to us with huge family history where diabetes and obesity are so much rampant that if somebody is not obese in the family, they say, what's going wrong? Try to understand, our mentality has gone so blunted towards the disease that we ask people, to thoda sa kudkud kyun dikh raha hai? Why are you not keeping well? But let us try to understand, we have to change our own eyesight to make us understand what is really normal and what is not. Look at this child now, it became a life-threatening disease for him. And what was the problem? The whole family was diabetic, so they used to encourage in the next generation that, okay, abhi to diabetes hua nahi hai, abhi kha le. These are few things where we have to make the families understand that probably they are making their next generation die much earlier than themselves. The premature deaths, the premature diseases, the premature complications which happen are happening because of a lot of negligence on the family's part, and probably the medical field has failed to make people understand what is the disease and how should they tackle it in the right way. We need to be more equipped, as I said again, to make our people understand how they should tackle the disease, how they should diagnose in time, and how they should try to go to a doctor to get it treated, and not something like a weight loss center where very hanky-panky things, very funny things are happening. Let's not make obesity a comedy show. Obesity is a disease. It is highly potential. It has got high potential towards multiple other life-threatening diseases, and we need to work on that. Look at this patient. You will see as if this is the green sari is somebody who is the younger one, and this is the older one. It is the otherwise situation. This is the first picture, and this is the after 1.5 years or 2 years. Obesity gets you aging. Obesity is a disease of aging. All the metabolic diseases get you aging very fast, and when we try to treat these people, we have to make them understand that probably we are going to work towards a complete anti-aging for these patients. This is how the operations have proven themselves. The best medical treatment alone versus the operations. Why it has become better? Because the metabolic set point, which was like a wild animal, has become like a tame person, and who is going to now respond towards your lifestyle changes and the behaviors. This is my last slide. You can see here n number of diseases which are caused by obesity, and n number of diseases which can get into a complete reversal mode once we treat their obesity. Including that is migraines, because most of the migraines are undiagnosed or under-controlled hypertensions. Pseudotumor cerebri means the disease where people experience transient blindness because of high pressure in the skulls. Dyslipidemia, we all know about that, the cholesterol, the main precursor of the metabolic syndrome. Non-alcoholic fatty liver diseases, we all know that liver transplants are needed, or liver failures are seen in people, more in fatty people than even alcoholics. We blame alcohol for liver failure, but the percentage of liver failure which happens because of just alcohol is only 10%, because of fat is more than 80%. So probably we have to keep fat as our first enemy when we want to talk about the liver from failing, keeping the liver away from failing. You can look at that, the metabolic syndrome, which typically comes with the central obesity, so not to neglect. If a woman has got more than 80 centimeters of the waist and man 90 centimeters, probably this is the right time to start up with treatments because central obesity is coming in. Type 2 diabetes, of course, yes, can get reversed up to more than 83%. More than 83% of people, if treated in time, can totally come out of type 2 diabetes, and the rest of the people, that is 17% of people, may come down in terms of complications, will come down in terms of medical management required, will come down in terms of diabetes control. The polycystic ovarian syndrome, we all know now it is not treated as only ovaries disease, it is treated as a part of metabolic syndrome. The venous stasis disease, which comes because of the mechanical impact of the central obesity. The degenerative joint diseases, we see that at the age of, maybe my grandfather underwent knee replacement at the age of 85. My aunts and everybody, the second generation, they had needed it at the age of 65, 70. I am seeing my friends getting it done at the age of 45, 50 also. Same thing for hypertension, same thing for diabetes. The diseases are skipping decades and coming so much prematurely. And it is not that we are only genetically exposed. As I said, we are unable to understand the matching between our lifestyles and what we are doing. So typically the caloric requirement, the sarcopenia and the metabolic syndrome are going to be they need to be focused when we are going to treat these patients. Only one angle if we treat, then probably we are not doing the complete job. Look at the stress in urinary incontinence. You will see a lot of females coming with urgency of urine. They cannot just wait till they go to the loo. And why this happens is because of the high pressures which fall on the pelvic floor. The pelvic floor goes into a very bad tone if the central obesity stays with them. And let me tell you, because I am a woman surgeon, I am experiencing so many stories from the patient, I am able to listen to them. Urinary incontinence can lead to a very bad relationship, a very psychological depressive situation in the family, in a woman. So if somebody tells you that she has got stress incontinence, just do not neglect it. It has got a huge impact as far as her happiness and her relationships are concerned. GERD, patients with acidity. Patients with central obesity will always have acidity because number one, the fatty liver comes. Number two, the gallstones come. Number three, the valve which keeps the esophagogastric valve, those valves stay open because of the high pressure which is intra-abdominal. And these are going to be the things which are going to make them patients liable for acid peptic diseases. So if I go on treating 1, probably then again I am treating it incompletely unless and until I treat the central obesity of the patient. Hypertension, as you know very well, that extra 10 kgs when we gain after we cross our BMI of 25, the vessel length which our body needs to, the heart needs to tackle is more than 30 miles. Extra 10 kgs means 30 miles of extra vascularization that comes into body, wherein the heart has to work for those many miles extra. And that is where hypertension should not be neglected when combined with obesity, because you treat the obesity, you get those 10 kgs down, automatically the things start reversing, the heart starts staying happy. Hypertrophic myocardiopathy is one thing which leads to sudden deaths in huge people. Huge people die suddenly because of two reasons. One is obstructive sleep apnea, and second one is the cardiomyopathy, which is hypertrophic. We can save them from this if we take down their obesity. Of course, the cardiovascular disease, asthma, as we all know, asthma in obesity does not belong to the bronchial asthma. It is not a disease of the lungs. It is the disease of the shortness of the breath. It is the mechanical shortness of the breath because neck is gone big. The apparatus which is dealing with your breathing is all under compression. It also leads to a high diaphragm, which doesn't let you expand nicely as far as the lung expansion is concerned. The sleep apnea, we discussed about it. One example I will give you, the Chernobyl atomic nuclear center, the accident which happened because of the person who landed up with obstructive sleep apnea due to central obesity, who just dozed, and it led to a lot of problems. A lot of accidents can happen because of this, because the person is high with carbon dioxide levels and he is unable to take any decisions at that particular point of time. And of course, depression, last but not the least to be neglected, because it impacts the complete vitality of your body. I think I will stop here. There is a huge amount of thing which can be talked about it. when I entered obesity subject almost 15 years back, I just thought that probably I'll do some operations, patient will get rid of obesity, patients will be happy. But the more and more I'm trying to understand my patients, more and more I'm trying to know about the thing, the subject is an ocean. Let me tell you, every single thing which we eat, which we practice, which we do, has got a linkage with your metabolism. And probably we need to be really waken up. This is an awakening call, I will say, where we need to make ourselves much more geared to tackle this problem of diabetes. Thank you very much. Thanks again.
Obesity is disability. It invites other diseases without our knowledge. And children today, they sit and eat. They will sit in front of the TV. They are gone eating and eating. And it is too much. Thank you, Dr. Jayashree, for your beautiful talk. Thank you. Friends, to conclude, I read about cancer only. I entered Kidwai Cancer Hospital as a resident. Maybe it is too late. So we have to educate on cancer and increase the consciousness about health right in the school itself. School, colleges, universities, not only health university, other universities, agriculture universities, farmers, because they use a lot of fertilizers, misuse of fertilizers, and preservatives they use to pack the food, and we eat happily. That is all causing the problem, and we should involve everyone, including women agriculturists, so that we can encourage more on organic farming. And we have to concentrate on herbal gardens. Friends, I will tell you, I had a mole in my eyebrow. I was worried so much. I was searching for a surgeon who is expert with the facial surgeries. I tell you, just I applied aloe vera and my mole disappeared. That is how I came here in front of you all. There is a way, that is our Ayurveda, and lot of Sanjeevani is available there. When I was reading for my examination MCH, I read about this cisplatin that is used for all the solid tumors all over the globe, and spending millions and millions, billions and millions on the research. Why can't we find such Sanjeevani in our gardens, in our forest, in our country? And it is going to help us quite a lot, because our treatment, cancer treatment, is very, very costly, and that will hit our GDP. Maybe we have to take lot of interest with Ayurveda, and patient choice is important. Patient is God for us. And our Prime Minister has made it very, very clear that yoga is going to stay in the treatment of cancer. Thank you all.
Thank you so much, ma'am. As we have reached to the end of today's session for the Oncology Symposium, I would like to request the respected chairperson to felicitate Dr. Senthamil R. Selvan. Thank you so much, sir, for the enlightening talk on the immune system and cancer, and the encouragement for the quality yoga research on it. Thank you. Now I request ma'am to felicitate our another respected speaker, Dr. Jayashree Totkar. Thank you, ma'am, for the immense amount of knowledge that we could acquire from your presence over here. Thank you so much. Now, I would like to request Professor Alex Hankey, distinguished professor of the Division of Yoga and Physical Sciences, S-VYASA University, to felicitate our respected chairperson, Dr. Vijay Lakshmi. Thank you very much, ma'am, for gracing us with your presence. I'd also like to thank the audience for their patient listening. Now,